All right. So, hello everybody again. We're going to be doing chapters 16 and 17 combined. So, just kind of a disclaimer. This is going to be a lot. So, some of this is review. Chapter 16 for the most part is review, but don't be too shocked if it could get a little boring at times. But at least the whole point is to review this because we've seen these meds before, but now we're just going to go a little bit deeper into them. 17 is brand new, so that'll be a little bit more of a learning experience. So try to maybe take breaks or rewind, or I don't know if you fall asleep, but
Power through like a G.
yeah, power through, power through. All right, so we'll just go over this kind of on a quick kind of touch on stuff, right? Just so we kind of know what's going on, right? Depression, obviously, we've kind of seen that as like a sad, despondent mood. It's obviously a very common mental health issue, especially among older people. Biggest thing is that for MDD, right? That's the main depression that goes on. You need to have at least 2 weeks of that kind of these following symptoms in order for that kind of diagnosis to occur. More often than not, it occurs due to difficulty sleeping or sleeping too much, right? So too much sleeping, hardly any sleeping, being very tired even with excessive sleeping, and that's something that that's like very prevalent when it comes to depression. Abnormal eating patterns, either eating too much or too little as well. And then there's very vague symptoms, which can sometimes be addressed as somatic symptoms. And that could be an array of I just don't feel fine. I don't feel normal. I feel very tired. I feel weaker than usual. It's kind of like that. This little red box is something that is directly from the book. And during lecture, she did say that out loud. The feelings of despair, guilt, hopelessness kind of makes sense, right? It's depression, trouble concentrating. A lot of this, it could start affecting your ADLs, which has a lot to do with cognition and you being able to process things. So concentrating could be affected. And then there also is an obsession with death or suicidal ideation, the SI. That's the most extreme or terminal part of depression, unfortunately. And obviously, being withdrawn includes social isolation. There's also lack of interest in appearance, hygiene, kind of just your overall look, or even sex because the mood is very low. And then at the very bottom, we have delusions or hallucinations, and that's going to be more associated with the psychotic depression that is going to be talked about in the next slide. And then just for like a quick little reminder, I did add this. One sec, let me just make sure this laser pointer works. I did add this, for at least 2 weeks, and this kind of just works off of the next slide. So there's a couple other conditions that go on, and then everything's color coded for your convenience to be able to distinguish everything. And a lot of this information is directly from the book. So obviously, we already talked about MDD, right? Major depression, depressive disorder. So going just a little bit into postpartum depression, right? It kind of occurs a lot because of a lot of intense mood shifts due to a lot of hormonal shifts that occur prior to delivery, after delivery. There's so many things going on, right? So and we've seen it before in OB. It can be a very common occurrence. So one of the biggest things that the book emphasized was encourage screenings. In terms of seasonal affective disorder, that one is more related to issues, when it's very dark, right? Like in those winter months or in areas like Alaska, the darker areas of the world. That the biggest issue there is that your body, when it's very dark in your pineal gland in the brain, happens to release more melatonin. Melatonin, if I recall right, is I'm not entirely sure if it's a hormone or a neurotransmitter. I'm more leaning towards neurotransmitter that kind of produces you a feeling of sleep, right? That's why a lot of people buy over the counter melatonin in order to go to sleep. But obviously, in very dark areas, your body will start releasing more melatonin because it thinks, oh, it's time to go to sleep. And that's where the seasonal affective disorder comes in, right? In the darker months, sometimes people can feel that way. And then at the end, we have the psychotic depression, right? That's where the whole intense mood shifts and very unusual behavior. Because it's psychotic, it has a lot to do with psychosis. There's could be a lot of loss of contact in reality, hallucinations, delusions, disorganized speech. And in conjunction with antidepressants, antipsychotic medication would be necessary for obvious reasons. So this is just going to be kind of like a quick little thing. Again, everything is color coded for a reason. So just kind of to put a little bit of like a warning. Light blue will be anything that is an SSRI. And this little violet color, you'll see it better if you're following along with the slides. Is TCAs. The green is SNRIs, or usually any atypical antidepressants. These will just be used for future reference, or just to get you more associated with it now. So the big things that I've noticed, at least when it comes to later in the slides, is that the red is obviously going to be things that are very dangerous, things that we really want to be mindful about. And the reason why this blue is going with this red is that it's supposed to link up to serotonin syndrome. That's something that we will kind of go over a little bit further, but it's something like the red just kind of signifies the certain symptoms that serotonin syndrome can have, especially if taking too many like an SSRI overdose or MAOIs and stuff like that. But we'll go over that later, right? So obviously, monitor vital signs. We know that. Monitor for dizziness, headache, and nausea and vomiting. So the biggest thing that's come to notice when it comes to these drugs, obviously they cause sedation, or they have the capacity to cause sedation, dizziness, drowsiness, all those types of things. And right, that could lean into causing a fall risk. So being very careful about that. Headaches, nausea, vomiting, that's kind of generic. So honestly, there's nothing life threatening to that. Obviously, when it comes to serotonin syndrome, one of the biggest things to watch out for is anxiety, the disorientation, agitation too, sweating, and fever, along with tremors. So the big thing to be mindful, right, is again, as I've mentioned it before in previous videos, the neurotransmitter video is the biggest help, because knowing your neurotransmitters and the receptors that they target helps us understand why is it that too much serotonin can cause these types of symptoms. We've talked about how serotonin is used for muscle contraction. It's used for sending a lot of messages in the body. And the whole idea is, again, your body's overloaded with all these chemical messages that could make it much more triggered into causing anxiety. Right? Serotonin helps hand in hand with kind of like happiness, long term happiness, muscle control, and everything. It gets your attention. Right? It helps with motivation. Same way as dopamine. Right? So if you have too much serotonin, you're going to get into this state of anxiety. That's where that comes in, right? And if you're overly anxious or you're overly worked up in your head, you're going to get disoriented as well. That could, it could also make you irritable. That explains the agitation. The diaphoresis and fever, I mean, those go hand in hand, right? If you get a fever, typically you start sweating a lot in order to stave off that fever. So now moving on to the next thing, right? A lot of neurologic status, and that's for all of these, right? SI is the biggest one, but in general, just neurologic status, asking your patients, hey, how have you been doing, right? Have you been, still feeling low, whatever. But the big thing to be mindful about, and again, color coding is very important, is the violet color for cardiovascular and this like brown orange kind of color for cardiovascular status. Now, again, we've covered this before in previous videos about how TCAs collect up in the heart. And just like a quick little reminder, TCA's mechanism of action happens to cause a reuptake inhibition of serotonin and norepinephrine, right? Again, because I'm going to say it ad nauseum, our neurotransmitter video is vital for you to understand why is that very important. We just said that TCAs collect up in the heart and they prevent the reuptake of norepinephrine. Norepinephrine happens to be a hormone in the body, or I'm sorry, not a hormone, a neurotransmitter that targets alpha 1, increasing vasoconstriction, and beta 1, that increases the heart's modulation for contraction and, forceful, and like it increases the pulse of the heart. So, if it collects up in the heart, that can lead to an MI. If a person is in a how do you say, like a if they've had history of MI, or they have like a very they have to be careful with their cardiac history or their cardiac health. That could lead into issues. That brownish color is for MAOIs, right? MAOIs are the most dangerous antidepressant, and they're usually the last line of defense when it comes to it. And they carry a lot of cardiovascular issues that can occur too, because we'll get more into it later. But keep in mind that those two, TCAs and MAOIs, are very important when it comes to cardiovascular status, because they can be compromised a lot quicker than the other ones. Obviously, monitoring mental and emotional status, that one's kind of standard. Um, Monitoring for underlying psychosis, right? Again, if patients are getting worse, that could mean that they need an antipsychotic medication. Sleep wake cycle, right? A lot of people will end up sleeping a lot more. It's a heavy occurrence, right? And that could stunt their growth, that can mess them up. So we need to be careful about that, right? And there's that, big giant assess for suicide because that is occurrent with a lot of these antidepressants. Monitor for renal and GI status, right? So again, the big thing is that now it's split between TCAs and SNRIs, right? And those we've talked about how TCAs have a direct anticholinergic effect and SNRIs have a anticholinergic like effect. So we're just going to kind of put them sort of in the same category in a way. And a lot of anticholinergics can lead to a lot of constipation, or lowered kind of GI kind of status. So that's why it's important to kind of be mindful about that. Liver function and hematologic status, that's kind of standard, right? The liver is very important when it comes to producing blood cells or blood cell regulation. So, these go kind of hand in hand, and a lot of drugs are going to just affect the liver regardless. Visual acuity, again, we've said anticholinergic. As mentioned before, neurotransmitters video. Off of the bat, if you hear anticholinergic, you are supposed to now just imagine blurry vision, dry mouth, constipation, um, all the other symptoms that occur with anticholinergic effects already off the bat. That's where the visual acuity comes in, right? TCAs and SNRIs have anticholinergic like activity and they can lead to blurry vision because the eyes are the pupils are too dilated. And then obviously ensure patient safety, and that's the big one with orthostatic hypotension. And I just did add this on. This is just something I've noticed a lot more with these antidepressants, is that TCAs and SNRIs, but especially TCAs, and I'm gonna also throw in MAOIs as well. Orthostatic hypotension is bigger in those drugs than it is in like SSRIs. So I guess for right now, like we'll move on to the next slide. This is just more FYI. I don't really think it'll be used in an exam, but it's kind of nice to have. And this is directly coming from the book, this orange box right here. Take a look at it at your own leisure. I'm not going to go all full into it, but the whole idea behind this is just to know that obviously the approach to any mental health issue is both medicine, like pharmacologics, and non-pharmacologics, like therapy, right? Counseling, behavioral therapy, psychotherapies like interpersonal therapy, CBT, psychodynamic therapies. Those are just very helpful. And as soon as you hear therapy, you just know it's an adjunctive thing, and it helps out. Just as much, it's just as important with medications. And that electroconvulsive therapy, right? That one's the last line of defense, right? Although it is very effective, which is very surprising, it also does carry a risk itself, right? It could lead to seizures. There could be complications with anesthesia, which is kind of a blanket statement for a lot of surgeries or procedures, and death can occur as well, right? But somehow, surprisingly, ECT is very effective, and that's backed up from our pharm book and our psych book as well. Right, so moving on to the next slide, right? Again, everything is color coded for your convenience. I'm not going to go super heavily into this because this video is going to be long as it is. So this is just more supplemental info, right? The blue is for SSRIs, the violet is for TCAs, and that brownish little color right there, the little box that you see right here, that's going to be for MAOIs. So that'll kind of help you out if you kind of need any other info. All right, so first of all, right, before we get into it, right, I want to establish that there is kind of like a safety index when it comes to antidepressants, and it's something that I've noticed, right? Like I could be wrong, but I'm kind of noticing a pattern here. SSRIs seem to be the most safest antidepressant. In fact, they're usually the first line now because of their safety margin. Obviously, they have undesirable side effects, but they're much more safer than the other antidepressants. So we're just going to put in our head, right, SSRIs are the safest. The second safest would be atypical antidepressants like SNRIs. And there's various other types of antidepressants within that family. The third safest would be TCAs. And then the fourth safest would be MAOIs, basically making them the most dangerous. But again, if nothing else works, there's a reason why they have a use. So we'll get into SSRIs again. We've talked about this before a couple weeks ago, but we'll try to touch on it very quickly, right? So SSRIs, obviously, we have our prototype drug, which is Sertaline, which is Zoloft, right? Um, Unfortunately, for a lot of the medications that are SSRIs, you're good, you're good. For a lot of the medications that are SSRIs, unfortunately, sometimes you're just going to have to memorize them. But hopefully, with it just being the prototype that we've been told to mainly watch out for, hopefully Zoloft is enough, right? So obviously, the main use is depression. We have seen for other stuff too, and we'll talk about it in a bit. But already off the bat, I want you guys to know that sexual dysfunction, weight gain, and anxiety, well, actually, sexual dysfunction and weight gain, that's kind of like a standard side effect that's going to occur with all antidepressants for the most part. They're all going to cause that kind of issue. So these are just going to repeat. Like, this is kind of like a, take that as a blanket statement for all these other antidepressants. The anxiety and the insomnia we mentioned before, right? Since serotonin is being inhibited, being taken back into the axon terminal, serotonin is going to have a longer time in the central nervous system. Too many messages kind of overload you, right? What happens when you're overloaded? You could get anxious. It could lead to that anxiety. What happens if you're anxious? Can you really fall asleep? Not necessarily. That's where the insomnia comes in. The less common side effects here are the sedation and anticholinergic effects and sympathomimetic effects. So we've talked about it once again, going back to that neurotransmitter video. Anticholinergic effects are very similar to sympathomimetic effects. So they're both kind of in the same category. It's just what is causing it that's the difference. Um, Sedation is a classic symptom of anticholinergic effects. It's not really for sympathomimetics because that's your fight or flight, but sedation is very common in anticholinergics. That's why when people take Benadryl, which is a, not only is it an antihistamine, but it's also an anticholinergic, they could get drowsy with it. In comparison to someone being given something like adrenaline, which is a classic sympathomimetic medicine, that can, it's not going to make you feel sleepy. So that's kind of like a little difference, right? So going into it a little bit more, right? So the yellow is more indicating to what it is used for. The blue is a little bit more about like what is the drug doing. So obviously it could be used for depression. It could help out with social anxiety disorder, that agoraphobia that we've seen before. It can help with OCD, PTSD, and premenstrual dysphoric disorder. So a lot of these, I'm noticing a pattern, right? It's a lot of stuff that can lead to depression, right? Depression itself is depression. Social anxiety, right? Self-isolation, that can cause depression. We're social creatures. We need stimulation from something, from somebody else, right? So that's where the depression comes in. OCD, right? We get so caught up in those obsessions and the compulsions that come from it, that can lead to depression. PTSD, I mean, I don't think I really need to go into it, how it could lead to depression. And the premenstrual dysphoric, right, dysphoria, that just classic, bad feelings. The antidepressants can cause, an anxiolytic property, right? Just getting rid of anxiety. That's why we've seen it. It could be used for the anxiety. Um, Obviously, it leads to an enhancement in mood and an improvement in effect, right? So mood. So the biggest disclaimer, and who knows, maybe this could be a question, is that SSRIs will not solve the mental problems behind depression. They can only really help the motivation behind it. That's where therapy comes in. That's where all that helps. Because a person cannot solve their problems without getting help, whether it's looking into themselves or fixing their actual issues in life. Medicine is not just the only option. They should be used in conjunction with therapy, right? And it takes a while for them to work. And that's a blanket statement for all of them. For all antidepressants, they take a while to work. They take at bare minimum like 2 weeks at the earliest. There can be other cases where people will say, oh, it's helped me in a week. But that's not the norm, right? The norm would be 3 to 4 weeks at best. And that's why it's important to tell the patient, hey, stay compliant with the medicine, right? So administration things, right? It could be given in the morning, and the main idea is because you want to prevent insomnia, right? Like, because they can lead to insomnia. So usually drugs that cause insomnia you give in the morning. However, You could also have to give it at night, depending on the patient. This is all like your classic it depends situation. Because if a patient gets more sedated than they do get anxious with an SSRI, you need to give it at night. Because if they end up going into like a car, right, they can, heavy machinery that can cause an issue, and then they could get into an accident. Interesting thing that is a little bit unique when it comes to SSRIs. I've never seen this type of thing in any of our presentations or slides. This drug can be given in an oral liquid. It could be given with water, ginger ale, lemon, like lemonade, orange juice, whatever, if it's in the liquid form. I guess it's just because it tastes really bad. I'd just picture that, right? So interesting. This is very unique. So if it has an oral form, like an oral liquid form, take with something, like, just to make sure it doesn't taste horrible. So big thing, right? You see a star, that means it's probably very important. Abrupt discontinuation. So our body is very, like, what happens when a person takes too many steroids, for instance? The body is so adjusted to this additional exogenous, influx of steroids that it stops producing, or it minimizes its own production of those steroids. The same effect occurs with SSRIs, because you're getting this influx of serotonin from or not necessarily you're getting an influx, right? Your body is getting adjusted to having much higher concentrations of it, because this drug helps prevent the reuptake. Um, your body will start going through withdrawals if you quickly discontinue the drug. As mentioned before, if our body's used to a higher pace or a slower pace, anything that is the opposite will trigger it. So abrupt DC can cause your classic withdrawal symptoms of nausea, sweating, agitation, tremors, insomnia, and seizure. Funny enough, that's also kind of like a sign of serotonin syndrome. Some of those are a sign of serotonin syndrome, but I guess it's what the context is behind it. But as mentioned, and this goes kind of classic with all the other drugs that we're going to talk about. If we DC too abruptly, our body's too adjusted to having higher concentrations of norepinephrine or dopamine or serotonin or whatever is the situation, right? So because of that, if we remove it, we're gonna have problems. If you guys see this tornado, this little red tornado, which you're gonna see it in every drug for this video, it means it's not for pregnancy. It, like, you have to out, the risk has to outweigh the benefit, or I'm sorry, the benefit has to outweigh the risk. And honestly, that's for all of them. So nothing really special, because they're antidepressants and psychotics. So adverse effects, right? We've kind of went over them. If you see a gray box, that means we've talked about it before. But the agitation, again, comes from the irritability, the anxiety that comes from too much serotonin. The headache is a classic just issue that happens. Dizziness, it's an antidepressant. Anything that's a CNS altering drug usually causes a dizziness. It could cause a drowsiness. It could cause. So those are just classic symptoms that you kind of have to associate with all these drugs. Somnolence is another way to add on to the insomnia, right? It's restlessness. It's not like feeling like you're really going to go to sleep. And fatigue. What happens when you don't get sleep? You're going to feel fatigued. So that's where it really is coming from. Obviously, you have to be very careful with people who have, a history of cardiac issues, hepatic impairment, and that one's kind of obvious because that means they can't metabolize the drug as much, so they can fall into toxic levels very quickly. Seizure disorders, again, serotonin, it's a neurotransmitter. It's helping with the electrical messages that go about that could facilitate seizures. So very mindful about that. Um, we're going to get into the whole why watch out with SI, right? Mania or hypomania. So one of the biggest things that I've come to notice, and this is backed up from our psych book, is that bipolar disorder is not really to be treated with antidepressants, not anymore, because serotonin, again, has a lot to do with the motivation, it has a lot to do with the attention, all that kind of stuff, right? And muscle control as well. So if a person is in a hypomanic state or in a depressive state during having, like bipolar disorder, they can end up, if you give them more serotonin, you run like they're in that spectrum, right? Here's like agitation and mania, here's complete depression. So if they're here and you just gave them, the SSRIs to like bump up the serotonin, and serotonin is what's modulating and helping and could facilitate a manic episode, you might push them towards the mania or like trigger a manic episode. So they're not really meant to be. It's more controversial now to use SSRIs with people with bipolar disorder. So, and the cardiac disease that goes hand in hand just because of, again, it's a neurotransmitter, it's a messenger. Anything that's altering the messages, the heart can be attacked in some way. Like, we're not saying like a heart attack for 100%, but the heart can be affected in some way because of these neurotransmitters. Black box warning, several stars. You're going to see this for all of them, but there is one special thing in this one out of all of them that I've seen that is very, very different. And it is the fact that although, any antidepressant, there's an increased risk per the black box of, leading to a state of like more suicidal ideation. Why is that? It's because SSRIs help improve mood and affect, right? Your mood is up, your affect is up, you're more motivated. So again, it doesn't treat the thoughts 100% of the way. That's where therapy comes in. So if you have suicidal ideation and you're taking these SSRIs and now you have energy and you have the motivation to do it, it could, it could cause a facilitated, like, it could kind of push somebody into actually killing themselves. That's why it's important to reassess, right? The big thing is that when it comes to this, this SSRI, or just SSRIs in general, because we're going to pair them with it, it's that they're not meant for pediatrics when it comes to major depressive disorder. But somehow, it's very interesting that it's approved for pediatrics for OCD, not MDD, but it's for OCD. That's very unique. I would maybe want to just make a mental note of this because it's so unique. All the other antidepressants that we cover say that they're not for children at all, right? No matter what the context is. This one, the only context that allows for SSRIs, we're just going to be general, is that they can be used for OCD for children under 6 years old. Very unique. That is not seen again. So be very careful with that. Contraindications, right? So using Zoloft with MAOIs, right? We'll get into more why MAOIs are so dangerous, but I guess to be very quick with it, the issue with MAOIs is that they happen to inhibit a very important enzyme that breaks down several neurotransmitters. If you get rid of the thing that normally regulates that, the neurotransmitter concentration, and just allow it to be too much, you're just adding to the problem. Pimozide is an old school antipsychotic. That's, so again, you're kind of mixing all these drugs. They're usually meant to be independent, right? Sometimes it could be used with a different category of drugs, but adding more just causes more risks. Surprise, surprise, right? So Antibuse, right? That's the brand name of disulfiram, or I don't know if I said it right, but I'm just going to say it that way. Antibuse happens to be a specific medication used for people who have a history of alcohol abuse, right? And it's using negative conditioning to prevent them from wanting to drink, because when they take disulfiram, if they take anything with alcohol, their body's going to get pretty much a horrible like reaction where they vomit, they have diarrhea, they feel really horrible, they feel ill. That's the negative conditioning. SSRIs happen to have a bit of alcohol in them, or like trace amounts of alcohol, and that can trigger an issue if taken with antibuse. So, careful with that. And this is where it's coming from. I highlighted this in blue, meaning that it's talking about the SSRI for more health, right? Moving on to the next thing, right? So interactions, right? SSRIs happen to bind more with proteins, right? And that's albumin in the serum. So chances are that albumin has a higher affinity for SSRIs than it could have for other dangerous medications like digoxin or warfarin, right? So if a person is taking, for instance, digoxin and warfarin, and they're also taking SSRIs, not only is their life probably terrible, unfortunately, but they run the risk of all the, the albumin kind of attaching more to the SSRIs, and then now digoxin and warfarin just freely float in the blood much more. If it's not attached to something, it's much more pure. The drug is pure. That can lead to the toxicity, right? So digoxin, we know the digoxin toxicity. Warfarin, we know the toxicity behind that is just a lot of bleeding. And I did add for later, right here, use with MAOIs, right? They can cause NMS, which will be very significant when it comes to antipsychotics, but they can be caused here with MAOIs and SSRIs. They can also lead to extreme hypertension, which kind of goes hand in hand with a lot of these SSRIs, right? Serotonin syndrome, if I recall right, can also lead to extreme hypertension as well. So it's kind of like a pattern that's going on. A lot of these neurotransmitters can facilitate hypertension in a bad way, like in an adverse effect way, right? Not a common side effect. It's more just really bad. And then SES is just the abbreviation for serotonin syndrome, and the highlight is just meant to help pair that up with it. So the confusion, the anxiety, the restlessness, the hypertension. Let's see, there it is. Tremors, sweating, hyperpyrexia, which is just a fever, and ataxia. So again, this is just your body's too overloaded with serotonin. Now all these things are going to be, at the extreme end of what's going on with serotonin, which is once again why it's very important to know your neurotransmitters and your receptors as well, right? And I did add this little box. I'm sorry, on your guys' slides it might look very blurry, but um, this is part of the grid, the med grids that we've made. So you have that for your reference as well. And we'll get into NMS a lot more later, the neuroleptic malignant syndrome. As for lab tests, right? They can elevate liver function tests, right? These drugs are going to affect the liver, so not anything new. That's kind of what's new. That's kind of standard. Big things to watch out for when it comes to herbal and food. People happen to take, and it seems like it's the like the first choice for a lot of people when it comes to like depression is to take St. John's wort and or L-tryptophan. So a little bit more to get into it, right? St. John's wort, I'm not fully sure if it's just tryptophan, but just in a different way, or it does have some serotonin in it. I'm not fully sure there. I just know that St. John's wort eventually contributes to serotonin, so it increases concentrations, right? Where if a person's taking SSRIs, which already is going to increase the concentration of serotonin, and they take St. John's wort, that's just going to add to the problem and add more serotonin, facilitating serotonin syndrome. L-tryptophan. So what is tryptophan? It's just the precursor to serotonin. It's the same way how T4, thyroid hormone, or just it's to add context, thyroid hormone. T4 is a precursor of the active form of thyroid hormone, which is T3. Same deal. And the big things for treatment of overdose, right? The symptoms of overdose, look at that. It's serotonin syndrome. And it's just repeating the same thing from last time. The big difference, though, is at the end, mydriasis is added, tachycardia, which, I mean, kind of standard, right? Your body's overloaded, and coma. The hyperactivity that can kind of go with the anxiety that's associated with it. But coma is new, and mydriasis is new. What is mydriasis, right? So mydriasis happens to be a overly dilated pupil. And one way I used to remember it is because I picture mydriasis, I think a drain, because it looks like drain, right? As the drain is bigger, water goes through it faster, right? So why do I use that? because the opposite of mydriasis is meiosis. Meiosis is a very pinpoint pupil. If I know mydriasis means dilated pupils, then I just know, oh, okay, then that means the opposite is just the opposite. Meiosis is that. So that's my reference point. Use it if it helps. And then at the bottom, I added this little stuff that came from the book. Treatment mainly includes stopping the causative agent and possibly mechanically ventilating, right? So a lot of emergency procedure stuff, and using muscle relaxers. We've talked about those before. Usually it seems like dantrolene is the big one when it comes to these emergency situations. It seems like dantrolene is the go-to. We've seen it before for malignant hyperthermia. It's very likely that they may be referring to that for serotonin syndrome, right? Because the tremors can kind of come in, like the hyperactivity and everything. So it could be like up reflexes and stuff. Left untreated, serotonin syndrome can cause death. So that's where we had in class like an interesting conversation, right? And it was more related to antipsychotics, but the same applies to here, right? It takes time for these drugs to work, right? And we don't want to quickly stop these drugs either. One, because of the withdrawal effects that can come of it. And two, because, so much time was taken, to get to that point. A lot of effort was taken in order for the drug to reach that therapeutic level. But now it's at a toxic level and it's life threatening because of the death risk. I feel like, because we in class we talked about it. Oh, but the patient, in terms of the extrapyramidal symptoms, they didn't have a life-threatening issue. They had a bit of a quality of life, right? Because they were having difficult movement, but their life wasn't at risk at that moment. I feel like the moment a life-threatening a condition occurs, that can justify the abrupt discontinuation of it. I can't really say for sure. That's something we have to we have to ask the teacher for that. We have to ask professor for that, because that's something important, right? Because what happens? Do we abruptly, stop, or do we taper like we're supposed to? The problem is that if you taper, you're still contributing to the problem in a way, right? So that's kind of up in interpretation, and I don't know. Maybe you guys can use that as homework. I'm gonna try to see about that myself. I don't really have the answer to that, so we have to ask the teachers for that kind of stuff. But it's an interesting kind of fork in the road that can possibly be a question. Who knows? I'd like to think that if there's a life-threatening issue, you should discontinue, because anyways we see that overdose treatment, because look, it's an emergency medical situation, it needs help, right? I would imagine that anyways a lot of the treatment, because there's no specific treatment, it's just supportive care, making sure ABCs are good. So that's why I feel like regardless, you're at this horrible point where they're in an overdose and they need help. I would picture you wouldn't continue giving this medication, even at the risk of the withdrawals associated with it, because there's life can be lost this way. But we got to do our homework. We got to ask in order to really be sure. And I won't repeat a lot of that because that was kind of a little tangent. Now we're on to the next category, right? Atypical antidepressants, SNRIs. But it's not just limited to SNRIs, because we have another drug that is an NDRI, right? So atypical antidepressants are basically anything that isn't an SSRI, but it's also not a TCA. So it's like that weird, like in the middle kind of thing. So for the most part, SNRIs include things like duloxetine and venlafaxine, right? Those you just, luckily they have like a naming structure to them, which kind of makes it helpful. Um, Big thing, right? They inhibit the reuptake of serotonin and norepinephrine, and they elevate mood. So very similar to antidepressants. It's just, which patient does it work better for? And then bupropion, Wellbutrin. Big thing that I've noticed, we've seen these in practice questions that we've made, is seizures. They are not to be used with seizures because it lowers the threshold to get a seizure. So, not to really be using that. And DRI just means norepinephrine dopamine reuptake inhibitor. That's all it means. And there is a brand of bupropion which is called Zyban. That one is specifically used for smoking cessation. So kind of with watch out with that. Um, Big thing that I've noticed with bupropion, that is one of the choice medications for seasonal affective disorder. So, and if I recall right, TCAs may also can be used for seasonal affective disorder. It's in our grids, so you can correct me if I'm wrong, but I'm pretty sure it was there in our grids. It's bupropion, and then there's another one which would probably be the TCAs. And then the big thing to watch out for is don't forget that SNRIs and TCAs can be used for pain, specifically that chronic long-term pain, that can't really be mended to, right? Now we have TCAs, tricyclic antidepressants. Oh, and I guess like a quick little, fun fact. TCAs and SNRIs, we've talked about how they can cause either anticholinergic or anticholinergic-like side effects. That includes a lot of dryness, dry mouth, not a lot of like secretion buildup. But for some weird reason, and this is very unique to TCAs and SNRIs, they cause a lot of sweating. Both of them do. That shouldn't really happen in an anticholinergic drug like these, but for some reason it happens. So that is very unique. That could come up as a safety thing, and we'll talk about it right now. So imipramine, that one, unfortunately, you just kind of have to memorize. I mean, I kind of did as well. Like over time, as we get exposure to these, you'll be able to kind of identify them. The nice thing is that I did add these, nortriptyline and amitriptyline. Luckily, them being TCAs, they end with tri, like tri TCA3, whatever, and they end with triptyline. So that makes them easy to remember. Imipramine, unfortunately, that one you just have to memorize. Same mechanism of action as SNRIs. They block the reuptake of norepinephrine and serotonin. Primary use, major depression, just like all of them, right? Big thing though, very big thing, and this goes hand in hand with SNRIs. Orthostatic hypotension is a risk with these, right? We've talked about them all the way at the beginning. It's the reason why this occurs is because tricyclic antidepressants not only have a direct anticholinergic block to muscarinic receptor 1, which is what causes a lot of these side effects of anticholinergic, but they have a block directly to alpha 1. Alpha 1, again, neurotransmitter video. What does alpha 1 do? It does a lot of vasoconstriction. So if you block alpha 1 from constricting the blood vessels, if, for instance, a patient stands up too quickly on these medications, they might not be able to compensate as quickly as they would. So they get orthostatic hypotension. This goes hand in hand with MAOIs, TCAs, SNRIs. The more dangerous the drug gets, I guess, and we only have 4 of them really that we talked about. SSRIs are the only ones that don't really do it. The other 3 do, for the most part. We already talked about how sedation is a common occurrence with antidepressants, so nothing new there. Anticholinergic effect, talked about it already. Um, Purple underline just helps for reference on anticholinergic effects. Gray box as well, we've seen it before. Cardiac dysrhythmias, we went over it in the safety part earlier in the slides. Why is it that it occurs? So again, yellow highlights is what it's for. Purple or violet or whatever you want to call it, those are just kind of like, what is it doing? So the big things to watch out for, right? So obviously it blocks the reuptake of serotonin and norepinephrine. So indications, obviously, major depression. But very interesting, unique things that TCAs can be used for is nocturnal enuresis and, bedwetting in children, which is kind of weird. I know I did say that, it's like weird that, these medications, other than like very rare things, are not indicated for children, but this one is kind of like another weird one, like how SSRIs are okay with like children in OCD. This one is, so I'm just going to redact a little bit of what I said earlier about the whole like the other ones don't do. This one, I guess, is just one of the only few exceptions. Bedwetting in children. There's also intractable pain. We talked about how they address pain and anxiety disorders, which a lot of these drugs already kind of help out with. regardless. Another interesting, unique thing is that they help with withdrawal syndromes of alcohol and cocaine. So that one's kind of a unique thing. So anything that has a gold box around it is just anything unique. So it's something to be a little bit more mindful. It's out of the norm. And then that red underline is just signifying how, look at that. The effectiveness may not occur for 2 or more weeks because these drugs take time to work. That's just how they are. They don't cause an immediate feel better feeling, right? Administration alerts, big things. There's that paradoxical diaphoresis, right? The sweating is a common side effect of TCAs. Therefore, their sweating is not a reliable indicator of hypoglycemia. Why is that important, right? Let's say a nurse, whatever, is at the nurse's station and they have an eye view of the patient and they're profusely sweating, right? And they have a history of, I don't know, being a type 1 diabetic or whatever, right? One of the common symptoms of hypoglycemia is diaphoresis, right? A lot of sweating, right? So the nurse looking off in the distance sees the patient and thinks, oh, the patient's sweating, but they're on imipramine. So that's kind of normal. It's like, so I'm not really going to look into it because I have this false sense of security that, like, oh, yeah, this patient, they're sweating because they're on a TCA. It has nothing to do with their hypoglycemia. So that's why it masks the symptoms. This is how I'm interpreting it because it's a safety issue, right? It gives you a false sense of security that, oh, it's because of the TCA. It has nothing to do with their diabetes. That's why you have to be mindful of it. This can go almost hand in hand with SNRIs as well because it's a safety issue. The minute it's a safety problem, we have to be aware of that, right? So, big thing, right? Gray box, purple underlines, those are just anticholinergic effects, right? The dry mouth, blurred vision, drowsiness, dizziness, constipation, nausea, vomiting, weight gain or loss, because these are weird, but usually it kind of leans more to the weight gain. And then that just unique thing of increased sweating that occurs. These drugs, as mentioned before, not to be discontinued abruptly because of rebound dysphoria, just meaning they're just going to go really back to that depressive state. Irritability, right? Because your body's used to these increased, neurotransmitters, and the minute you take them away, you're going to start feeling terrible. And sleeplessness, because again, are you going to be comfortable being in like extreme dysphoria and irritability? Not really. There's that tornado of pregnancy. Again, not really for it. Here's our adverse effects, and I did add this little star, has a direct block of alpha 1, right? There's that orthostatic hypotension. General side effects, we've already talked about sedation, we've talked about the anticholinergic effects, the cardiovascular symptoms that we've talked about before, right? TCAs collect in the heart, they prevent the reuptake of norepinephrine. Norepinephrine targets alpha 1 and beta 1. So I guess, since it has a direct block of alpha 1, we'll talk more about beta 1, right? And then beta 1 is the thing that makes the heart pump harder and pump faster. And it can cause, like problems with the conductivity of the heart, like a heart block or extreme hypertension, because it just forced the heart to work really hard, right? So you have to be careful with people who have like a very, I guess, like hairline, like fall kind of stuff when it comes to the heart. Um, any agents that mimic norepinephrine or serotonin should be avoided. Wow, what a surprise. Why is that? It's not like this drug happens to prevent the reuptake. It increases the concentration of norepinephrine and serotonin. So if you take anything that helps increase it more, you're just going to cause toxicity. Photosensitivity is another classic anticholinergic symptom, specifically because of the dilated pupils. Too much light comes in, you're like, I don't want to see that, right? That's where the photosensitivity can occur. Black box warning, again, so there it is, right? We've already talked about how they can increase SI risk, especially in young people and children and stuff. This drug is not approved for pediatric patients. Again, kind of weird because there's like a bit of a disclaimer because earlier there was a specific indication saying bedwetting in children. Chances are maybe it's more of an off-label thing with more monitoring. That might be likely what it's talking about, but for the most part, that's where, careful with that. Contraindications, it should not be used for anybody that's recovering from an MI. We talked about what happens with the heart. Defects in Brundle branch conduction, we talked about how it can cause heart blocks. So if they have issues already with the heart, the electricity, that obviously it's going to cause problems. Severe renal or hepatic impairment, renal because you can't excrete the drug, hepatic impairment, you can't metabolize the drug, so it causes more toxicity. And then obviously, this is a blanket statement for everything that isn't an MAOI, and if used with it, do not use within the washout period of 14 days while discontinuing MAOIs because they are very dangerous, and we're going to get into them in a very short amount of time. So, drug-drug interactions. Look at that. There's a lot to go behind when it comes to drug-drug interactions, right? So, use with other CNS suppressants like alcohol. Like we've seen with all these other drugs, do not use with alcohol because it causes more sedation. Cimetidine is an H2 receptor blocker, so it's a PUD drug helping lower acid production in the body, in the stomach specifically, right? So cimetidine may inhibit the metabolism of imipramine. What a shocker, right? Like, your stomach won't be able to break down the drug as much, right? So obviously it's going to be there for more like a concentrated level, and then it can cause toxicity, right? They can surprisingly reverse the anti-hypertensive effects of clonidine. Clonidine is an alpha 2 agonist, right? So chances are it could be that the fact that, clonidine affects the central nervous system primarily, right? In order to cause the vasodilation and heart rate, to slow the heart rate. So chances are it seems like imipramine, because again, it has a lot of alpha block. That means alpha 1 and 2. Clonidine is a alpha 2 agonist. So chances are it won't allow alpha 2 agonists to do its job. However, clonidine does have a little bit of that CNS depression because that's what it's doing in order to lower blood pressure and heart rate. So how I'm interpreting it is when using clonidine, you get no benefit of it, but you get the risk of it when you take it with imipramine. So kind of an interesting takeaway. Any use with oral contraceptives can decrease imipramine levels, so that's kind of interesting. Disulfiram can lead to delirium and tachycardia. I would like to maybe pair that up because we talked about disulfiram, right? I would want to imagine that maybe it's because TCAs happen to have a little bit of alcohol in them, so it causes this issue, right? Because disulfiram is not to be used with alcohol, or if not, you get those really bad side effects. And then antithyroid agents can produce a granulocytosis. So antithyroid agents, we've heard about these before, right? Those are methimazole, right, for hyperthyroidism issues, right? Because we want to address too much thyroid hormone, so we take methimazole. There's also a couple others, but mainly we're after methimazole, right? And methimazole, one of the most biggest significant side effects that can occur is a granulocytosis. It's bone marrow depression that can cause a lot of blood dyscrasias. So chances are it's just that it causes more of an effect with TCAs. Phenothiazines are a first-gen antipsychotic. We'll kind of go that more into it. But phenothiazines they increase the anticholinergic and sedative effects. We'll go into it a little bit later in chapter 17. Why does that occur? But I guess just as a quick teaser, first-gen antipsychotics that happen to be phenothiazines, they do a lot of anticholinergic effects. So this drug already does that. If you take it with another drug that does it, you're just going to make it stronger, right? Sympathomimetics may cause cardiac toxicity. We already talked about this drug, imipramine, TCAs in general, they can affect the heart, right? Because they can collect up there. So if you use anything that causes that fight or flight kind of, body reaction, one of the elements of fight or flight is the heart. So you're going to overwork it the same way. Methylphenidate or phenytoin is less effective when taken with imipramine. Methylphenidate is a drug for ADHD. It's a CNS stimulant, right? And then phenytoin is a classic anti-seizure drug. So Big things with this is just it just lowers the effect of those drugs. And chances are it's probably just because, I don't know, imipramine just counteracts their effect or something, but just careful with that. Use with MAOIs can cause neuroleptic malignant syndrome, which we've seen before with SSRIs as well. So careful with it. And with MAOIs, right? Because they're really, really dangerous. And then finally, at the end, we have things like herbals, right? Evening primrose oil or ginkgo can lower the seizure threshold. So these drugs, TCAs, have the capacity to lower the seizure threshold. So it's kind of like in the same light as bupropion, where it's not that it's contraindicated like bupropion is with seizures, but there is a capacity for TCAs to lower the threshold for a seizure. So more monitoring has to be involved. St. John's wort may cause serotonin syndrome, which is no shocker. Again, serotonin reuptake is inhibited with this. So if you take with St. John's wort, which happens to cause more serotonin concentration, that's where you will get the serotonin syndrome. Finally, for overdose, as we've seen before in the other ones, general supportive measures. There's no real way to target it per se. The big one, though, the big new one, right? Because we talked about, conserve your ABCs, airway, oxygenation, ventilation, right? AB. Or, but we have to be more mindful about cardiac rhythm as well, because again, we've talked about how TCAs can affect the heart, the conduction, and the physical mechanical system behind the heart, right? So very careful with cardiac rhythm. Luckily, just like a lot of overdose procedures, it's gastric lavage and activated charcoal. Those are kind of standard for any overdose drug. Like it's just supportive measures. It's no direct antidote. Finally, we've reached MAOIs, right? So they're the most dangerous drug, the most dangerous antidepressant. They are not a first line drug. Not at all. They are a last line drug because of how dangerous they are. Now, when it comes to MOIs, the only one that's really come up in our farm book is phenelzine. That one I just unfortunately had to memorize. Perhaps you can come up with something a little better to memorize it, but I just had to just memorize it through exposure and just repetition. Um, Mechanism of action, right? So it decreases the effectiveness of monoamine oxidase. What is monoamine oxidase? It is an enzyme that breaks down DA, dopamine, NE, norepinephrine, 5-HT, which is serotonin, epi, which is epinephrine, and tyramine, which we have this little neon pink underline below it, this hot pink underline, and we'll talk about that in a little bit later. Um, the big things with the primary use for it, I would imagine because of how dangerous it is, it's not really indicated for a lot of other things other than depression. But we'll see right now in the slides if anything else comes up. But I don't really think there's a lot more use for it because of just how dangerous this drug can be. Adverse effects, look at that, orthostatic hypotension, something we've mentioned before with TCAs and SNRIs. Headache is occurring, which is a generic thing that we've seen with all of them. Insomnia, something that happens with all of them as well. Now, again, just picture you're taking away the thing that is breaking down all these neurotransmitters over here. Imagine your body being on all these neurotransmitters. A lot of these, they do CNS stimulation, they can do inhibition, they do a lot of different things. I believe monoamine oxidase also contributes to breaking down acetylcholine, which we've seen the many different things acetylcholine does too. So imagine your body has all these different messages. Hey, let's go. Oh, hey, no, 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 let's calm down. All these things at once. That's what contributes to the insomnia because it's too many messages, too much stimulation, inhibition messages being just available. And whatever receptor that does the stimulation or inhibition is just open for the taking, and the body's going to feel probably not that great. Big thing they interact with a large number of foods and medications, and the hypertensive crisis can come about it, especially with tyramine foods. It's We've seen that with other, antidepressants, they can cause neuroleptic malignant syndrome, but with foods, the big one is a hypertensive crisis. And the thing that happens is because tyramine is a food, it's like a food byproduct, right? And monoamine oxidase happens to break it down in the GI. And tyramine contributes to kind of, allowing for more higher blood pressure. So if you don't break that down, that's where the hypertensive crisis comes in. So little adverb. Sorry about that. I forgot to put acetylcholine here too. But that's it's with all the neurotransmitters we've talked about within in the neurotransmitters videos pretty much. So the drug itself, right? MAOIs, right? They inhibit MAO. It intensifies the effects of norepinephrine, but they can also intensify the effects of several different other neurotransmitters. And they're mainly for the management of depression. And they can occasionally, seeing that again, because it's too dangerous, they could be used for panic disorder. Didn't really have a lot of other indications, just depression and possibly occasionally panic disorder. So kind of goes to show it's a pretty dangerous drug. When the indications are very little, that means the risk is really high. The effects of this drug after last dose can persist for 2 to 3 weeks after therapy is discontinued. So what's the big takeaway behind that, right? That's where the washout period comes in of um, usually it's 14 days. That's kind of the general one, but it could be a washout period of 2 to 3 weeks. So but usually in a general sense, it seems like 14 days is the marker. So obviously, washout periods of 2 to 3 weeks, that's the 14 days, right? That are required before introducing any other drug. Obviously, abrupt discontinuation can cause rebound effects, and that includes rebound hypertension. So a common side effect is orthostatic hypotension, right? So a lot of this low blood pressure stuff going on. But if you abruptly stop it, that's where you get this hypertension. So I guess we could look at it as MAOIs. It's very normal for people to get hypotension with this drug, but at the opposite end, these bad effects of MAOIs, it's a lot of hypertension issues. And then obviously we are to taper the drug, right? Not just quickly stop it. So let it wash out in that time, taper off the drug, lower the dose, and then you're good. And there's that tornado again, that it's not for pregnancy. Side effects, right? Pretty similar. A lot of anticholinergic effects, the constipation, dry mouth. There's that orthostatic hypotension again, insomnia, nausea, loss of appetite. Again, it can make you feel sick. Too many neurotransmitters, too many messages in your body. You're gonna feel sick. You're not really gonna want to eat. You're gonna feel nauseous. Your body is really up on neurotransmitters, so you're gonna have the insomnia. You could have the whole thing about, neural activity because all those neurotransmitters are coming. That's where the delirium could come in. Mania or anxiety and convulsions. Again, too many neurotransmitters are just allowed to get to the receptors because MAO is not being, it's not doing its job. That's where, again, anxiety comes with insomnia, the delirium, mania. All that stuff contributes to that neural activity because too many messages are out. Convulsions, again, we've talked about it. Convulsions is the most primitive form of heavy CNS stimulation because it's just so much, the body's overloaded. Severe hypertension can occur with foods that contain tyramine, which we'll get into which ones. And then seizures, respiratory depression, and circulatory collapse can occur in a severe overdose. All those things are very, very drastic and very, very dangerous when it comes to these MAOIs. Therefore, we have to be very careful. We went to why seizures, right? Respiratory depression and circulatory collapse, that's just basically the end all. Like that's life or death. That's like where it's the worst effect at all. So that's why MAOIs are so dangerous. Black box warning. Again, we've seen that. We've talked about it before. These can cause more SI risk for people that are young, not approved for pediatrics. This one didn't even have like a different one where it's like, oh, it could be used like TCAs when it says that TCAs can be used for bedwetting in children. This one had nothing else but depression and possibly being used for panic disorder. So this one for sure is not for children. It's too dangerous. Contraindications, right? Anybody with a history of cardiovascular or cerebral vascular disease, watch out with them because we went over the severe adverse effects that can occur with MAOIs. They're very dangerous drugs that can cause a whole collapse in the system, whether it's respiratory or cardiovascular. And part of it is the cerebral vascular system. Obviously, not to be used with hepatically impaired people because they can't metabolize the drug, therefore it stays in the body longer, more toxicity. CKD because they can't excrete the drug, so it stays in the body longer, more toxicity. And then there's phenochromocystoma, which is a rare tumor at the adrenal medulla. Let's kind of remember that from anatomy, right? The adrenal medulla is what causes, it's what releases norepinephrine and epinephrine above the kidneys. It's the little snow caps. So the adrenal medulla releases more norepinephrine and epi, right? Like in general, that medulla does that. It releases norepinephrine and epi. But this tumor, like we've seen in a lot of tumors, they cause more hormone of whatever the tumor is in, of like whatever gland, right? So very, very careful with that. Drug-drug interactions, right? Many drugs affect the action of phenelzine. Use with TCAs, SSRI should be avoided because of temperature elevation and seizures, right? That's where the whole, serotonin syndrome or NES could occur. Um, Opiates should be avoided due to the increased risk of respiratory failure, right? But funny enough, it could lead to a hypertensive crisis. So again, we're seeing this pattern of the worst stuff that these MAOIs do is a lot of hypertension. Obviously, opioids are a CNS depressant and they're a respiratory depressant, so they're going to just contribute more to respiratory failure because this drug just potentiates the action of all those. But hypertension is the abnormal. It seems like hypotension is the normal. It's the common side effect, but hypertension is the worst of this. Obviously, anything that stimulates the sympathetic nervous system, the fight or flight, can lead to, look at that again, hypertensive crisis. Caffeines can cause cardiac dysrhythmias and hypertension. Again, very, very dangerous things. Again, overwork of the heart, everything's really out of whack, and then there's that hypertension again. It just keeps coming up. A lot of hypertension with MAOIs. That is abnormal. That is very life threatening in a way. Phenozine, right? Big takeaway with this, right? Platelet functioning can be affected by MAOIs. Therefore, CBCs should be monitored because that could lead to blood, like a blood thinning effect in a way, right? So it can kind of facilitate severe bleeding. Herbals and foods, right? Use of ginseng, which happens to increase neurotransmitter release. And again, the minute we hear neurotransmitter, we can think, oh, it might be dopamine, serotonin, it could be norepinephrine, it could be acetylcholine or something else. Ginseng, again, it sounds like it's doing a lot of similar MAOI effects, right? And this MAOI already increases the concentration of several different neurotransmitters, right? And ginseng is just going to contribute to the problem. So, it can cause the headaches. We've seen that before. Tremors, right? Because the body's overloaded with messages. There's too much going on. So the body's like, you get tremors. Mania, we talked about that. Over neuro, like, agitation. So much stuff going on. Insomnia, again, anxiety that comes with it. Irritability, we've talked about that before. And visual hallucinations, again, it's overstimulation of the central nervous system. A lot of up. And look at that, we've seen this before. Mahuang, ephedra, and St. John's wort can contribute to more hypertension. We talked about these. These are all stimulant like herbals. anything with stimulant, they cause the hypertension. They cause over CNS like production, like activity, and then that's where you get the overloadedness. Treatment of overdose, kind of interesting, right? So, same thing, supportive treatment, no direct like line of treatment, right? So, you might have to make them vomit, they might get a gastric lavage, and they might get activated charcoal. Over central nervous system stimulation can lead to those seizures, right? Because we talked about it. Most primitive form of CNS stimulation, most heaviest, is a seizure. It can be treated with IV diazepam, which we must remember, we must monitor the patient when it's given IV, because we talked about it's a benzodiazepine, right? IV benzodiazepines, you must monitor the patient more for respiratory depression, right? So IV diazepam, which we've seen before, can, treat seizures head on, but you give it very slowly, right? I mean, that's kind of obvious. We don't really ever give like drugs like slam. There are a few drugs that do get slammed, but not these, right? Hypertension can be treated specifically with calcium channel blockers. Why is that? We had a practice question, and it came down to which one do you give, a beta blocker or a calcium channel blocker? I went with beta blocker thinking, oh, let's fix the heart, right? Let's calm the heart down. I completely overlooked that we're talking about hypertension. We're talking about high blood pressure from the vessels, the peripheral vasculature. Calcium channel blockers specifically target the ability for the peripheral vasculature to contract. This is the best option because it targets the hypertension directly rather than having the heart calm down and let it chill. Then the blood pressure can maybe go down. So don't do the same mistake I did. Hypotension and vascular collapse can be treated with IV fluids or vasopressors. That's kind of a standard emergency treatment. That's not anything new. That's more supportive care. And then body temperature should be watched very carefully, and respiration should be supported, right? Because again, these are emergency things. The body temperature thing is specifically, it's probably referring more to the neuroleptic malignant syndrome that we've seen before. And finally, here's a big box, right? This highlight box around is just, talking about that it's tailored to MAYs, and it's all foods that contain tyramine, right? So the biggest reference point that I'm using now is anything that's processed or aged. Or the big thing is that anything that ferments fairly quickly. So let's look at fruits, right? Avocados and bananas. So one way I'm kind of using it to remember the avocados and bananas is that typically avocados and bananas ripe very fast. They usually do. Have you ever cut open an avocado and then let it sit out like for a little bit? It gets really like kind of putrid a little bit, right? Bananas, leave a banana that hasn't even been opened in a hot car and see how quickly it could ferment, right? Raisins have been aged, right, and dried, so that one already kind of goes there. Papayas, same thing. They end up becoming, very ripe very fast. That can lead to the whole fermented and aged thing. And then meat tenderizers, I mean, those are just straight up processed. Canned figs, those are processed. Dairy products, right? Cheese, I mean, for the most part, cheeses are aged. Cottage cheese is okay, which is kind of cool. That one's kind of different. But for the most part, anything that's aged cheese or just like cheese in general that's usually aged, not to be used, right? But cottage cheese is okay. Sour cream, it's a dairy product. I mean, it's a processed product. Yogurt, it's processed as well. It's not just like it just grows in nature. Alcohol, anything with alcohol, just stay the hell away from it. It's just a blanket statement. Stay away from alcohol because they all have tyramine in it, and they're all processed anyways, and fermented and aged and all that. Meats, beef or chicken liver. So it looks like a lot of dark meats, right? Pate, that's processed. Meat extracts, nature just doesn't create meat extracts. That's processed. Pickled or kippered herring, those are fermented. Those are processed. Pepperoni, salami, sausage, bologna, those are hot dogs. Those are all processed foods. Vegetables, pods of broad beans like fava beans. Those are commonly fermented. Soy sauce. I mean, that one you just kind of have to memorize. It's soy sauce. Yeast. Again, those things are processed and aged. They're fermented in order to make, a lot of breads and stuff like that. And the one interesting outlier, but little backstory is interesting, chocolate, because the cocoa pods have to be aged and fermented as well. So a lot of processed stuff, right? Like honestly, if it comes from a little wrapper stuff and you open it or like a can, it's processed. It's not good.
Funny is caffeine's on.
That is funny. Yeah. All right, so now we're going to bipolar. I know you guys are probably getting tired of me talking a lot. I'm also a little tired too, but let's kind of push on through, right? So bipolar disorder, very interesting. Again, color coded for your convenience to kind of help you out. This is just a screenshot from the depression slides from earlier, so I'm not really going to repeat those just for brevity. But obviously, what is bipolar disorder? We've been talking about it for this past couple of weeks, right? It's commonly or once known as manic depression, right? So it's a lot of episodes of mania, right? Those 7 days minimum of mania with episodes of just generalized depression, not like crazy bad like MDD, but it's just generalized depression, right? Depressive symptoms are here. Again, take a look at them on your leisure, but we're going to go over the manic ones, right? So this is directly from the book, right? Mania, it's basically an increase in psychomotor activity and irritability, right? You're really hyper. We saw that video in small group, right? The symptoms could be the inflated self-esteem, the grandiosity, the just kind of thinking that you're really up and above, right? The less need for sleep, right? Usually people don't sleep with episodes of mania, so they don't sleep at all for the freaking long term of those 7 days. Increased talking, kind of like what I'm doing right now. Racing thoughts, it's that flight of ideas, distractibility. They're just really like, distracted and on their own thing. They can't focus on one thing. When it comes to like someone trying to get their attention, they're really self-centered in that way. I'm not saying it's like horrible or bad. It's just they can't help it. An increase in goal-directed activity we saw in that video. They get this like idea that they're going to fix the world or like cure something, and then increase in risky behaviors, right? Like a patient could be saying, "Oh, I can fly," and then they get on the roof of something and they say like, "Oh, look at me fly," and then we don't really want to get into that. So big thing for the most part, right? This is the big thing with bipolar disorder is that it is a mood problem, right? Like it's too much mania, you're too stimulated, you're too high and above, right? So this is where a mood stabilizer comes in order to, here's that high that you're in. Let's bring it down to normal. Here's like depression. Here's mania. Here's that, I forgot what it was called, that normal state of emotion. Let's kind of bring you a little closer to the middle, right? Like let's not overdo it, but let's not also underdo it. Lithium, Scalith, right? So the big thing, lithium, its exact MOA is a little unknown, right? And I did add this box. Again, I'm sorry if it's super pixelated in your slides. Again, you have access to the MedGrid, so you could see it in high definition, 4K, 8K, 400 FPS or whatever. But primary use, right? Bipolar disorder. But in class, she mentioned that it could be used with alcohol withdrawal paired with the benzo to prevent seizures, right? To help treat that alcohol withdrawal. So kind of interesting, two different indications. Um, Main adverse effects, excessive loss of sodium. That causes, big thing that we're going to notice is that sodium has a very big impact with lithium. We have to be very careful. We have to make sure that the patient has a consistent intake of sodium because if not, toxicity can occur. Because lithium has a very similar structure to sodium when it comes to inside the body. So the body will recognize sodium and lithium is the same thing. And sometimes, in cases where you lose sodium or you're hyponatremic or you've been vomiting or having too much diarrhea, losing a lot of salt, your body will try to It will try to conserve salt, right? But it notices lithium, or it interprets lithium as salt. So instead of reabsorbing salt like you're supposed to in order to preserve your salt, you instead absorb lithium back, or you reabsorb it, and that obviously can cause toxicity. And again, you'll see it here on the side effects, the general side effects of lithium: headache, lethargy, fatigue, general memory loss, nausea, vomiting, diarrhea, dry mouth, abdominal pain, anorexia, dry mouth. Oh, there's dry mouth again, funny enough. Um, Weakness, tremors, weight gain. So, weight gain, we already talked about how that's very occurrent with a lot of these medications, but if you've kind of noticed a pattern on this, these are all kind of the signs and symptoms of hypernatremia. It's a lot of that. So maybe to kind of generalize it and not be like, oh man, how am I going to remember all these side effects? Just kind of think, those sound a lot like hypernatremia. Obviously, the most extreme adverse effects is like circulatory collapse, which basically can go to up to death. But those we already have seen. Those are just the like a lot of. I mean, how more like life threatening can it get than a circulatory collapse? So that's just kind of standard. But we want to know common, right? We want to get early symptoms, not late. Everybody can identify a late term symptom. We want the early ones. And it seems like hypernatremic symptoms are very occurrent with lithium common side effects. So they seem like they're kind of very close. More information was here. It's kind of interesting. It's a little weird. Our pharmacology book did not really go into lithium that much. Went over it very briefly in the reading. Our psych book actually had more information with lithium, which is kind of funny. So big thing, right? Big things with the mood stabilizers. It's talking about lithium specifically, right? Obviously, we monitor mental and emotional status because of the SI risk. That's nothing new. We've seen that before. Monitoring electrolyte balance. That's a big one. And the big one is sodium, right? Fluid balance. We also don't want to overhydrate the patient because then they get hyponatremia by dilution, which will again trigger the body to try to reabsorb sodium to conserve it. And then again, they'll just identify lithium as sodium and just keep adding to the toxicity, right? That's why fluid balance and INO is very important. Obviously, monitor renal, cardiovascular, GI status. Those are just general, especially with lithium. Like it is very important, but those are general stuff that we see with all these medications. But let's kind of make a big emphasis, especially with lithium, because the bad, like, end of the spectrum kind of issues with like danger, it is the circulatory collapse and all that stuff. Big thing to notice: lithium is one of those that we have to actually know the therapeutic index. According to our farm book, it is 0.6 to 1.5 milliequivalents per liter, right? The most important is that 0.6, 1.5, right? Our psych book says a little different. It's 0.6 to 1.2. I did ask Professor about it, and because I told her like, different things are being said. She said that if she were to throw something in there, she'd make it a lot more obvious that it's out of whack. I'm interpreting it as that basically means that it would be over the 1.5. So over 1.5 toxicity. And you know what? Even in our psych book, it talks about how even though the therapeutic is 0.6 to 1.2, toxicity symptoms occur at 1.5. So it still agrees with the 1.5. So that's where the whole toxicity comes in. So anything above 1.5, we can expect toxicity. Anything below 0.6 is going to be just manic episodes, like, because it's not working. The whole point of lithium is to bring down the manic episode. If the drug isn't at a therapeutic range, the manic episodes are going to persist, right? Um, Obviously, big thing, you have to monitor the patient, especially starting every 4 to 5 days due to its long half-life. The levels must be monitored for 5 days prior to a dose change, and I would imagine after too, because you don't want to go overboard either. You don't want to have toxicity. And then I'm sorry, but like from what I saw too in the slides, this is like probably the most blurred picture in your slides. I'm very sorry about that, but it's just talking about how lithium acts like sodium in the body, and in conditions where sodium is lost, it can cause lithium toxicity. You're not missing out on anything crazy, and it's just saying monitor sodium
Yeah,
levels.
you already
So
said that.
yeah, and I already said that. So, but in case anyone was getting interested, because I know it's so interesting. It's like you're at the edge of your seat, just like waiting for this information, right? Some adjunctive things or medications that can be used for bipolar disorder. If a patient cannot tolerate lithium, right, they could use valproic acid, which is Depakote or Depakote, and risperidone, which is Risperdal. Valproic acid happens to be a anti-seizure drug. Risperidone is an atypical antipsychotic. It's a Gen 2 one, Gen 2 antipsychotic. And honestly, when it comes to bipolar disorder, I see this specific combination used a lot: risperidone and valproic acid. It seems like those. I mean, it does. It also helps that risperidone is like the first line for like psychosis. It's like one of the first line drugs, so or like the first choice. But let's go kind of why is it that it does, right? And then I added again our med grid like sections here. So if we can take anything away from it, valproic acid, the Depakote, that helps, and it's colored here. It increases GABA in the body. Neurotransmitters video from a while back. GABA is a natural inhibitory neurotransmitter. It also blocks voltage gated sodium channels to reduce neuronal activity. So it's like it's a body calmer. It's like a downer in a way, right? It calms the body down to prevent excitation in the central nervous system, right? Risperidone does everything to help with psychosis. In psychosis, you can have delusions, which what happens in bipolar disorder in episodes of heavy mania, you get delusions of grandeur. So those are still similar areas, right? They control because it's over CNS kind of like production and stuff, and like your body's really high and everything. So these two drugs work hand in hand to almost do what lithium does, because lithium not only does the whole thing with like adjusting sodium and stuff like that, and you know freaking doing several different other things that I wish I would know really off the bat of my hand, off like the back of my hand. But it has these two drugs happen to do together what lithium does independently. So that's why it's an adjunctive therapy. So it seems like it's kind of cool. If they can't use lithium, they can use Depakote and Risperdal.
Lithium,
Pretty cool.
doesn't lithium lower dopamine and serotonin and increase GABA?
Oh yeah, yeah. So okay, even better. Yeah. So looking into because that's a good quick reminder. Lithium increases GABA, and it can lower serotonin and norepinephrine. Which, again, if it's too high, the body's going to be really high. So lowering that, same kind of effect here going on, because it has a lot of similar blocks. So again, it's just that this takes over in that way.
It's basically doing that one drug basically does what those two drugs do.
Yeah. So look at what Depakote and Risperdal have to do to just do a semblance of lithium's power. It's basically that. Okay, role of the nurse, right? Obviously, drug history, rule out any medical or neurologic issues like, hypothyroidism, Addison's disease, like those low medical conditions that can show off as depression. Ask about alcohol and drug use, SI, kind of standard. You can't use alcohol with any of these drugs. Careful with the whole SI because the risk can go up. Um, History of depressive illness, right? Just family history, especially, like it just kind of helps with the whole diagnosis. Foods that have the tyramine, we talked about those, right? Um, Giving any information on, like the symptoms of dehydration and lithium toxicity, because again, it seems like they both have those similar, like dehydration and lithium toxicity produce those similar side effects, basically. And then obtaining vital signs, right? Liver and renal function, right? We don't want to have toxicity, cardiovascular, TCAs and the MAOIs, body weight, all of them usually kind of go up. And then therapeutic blood levels, right? Lithium. It's mainly talking about lithium, right? This we could skip because I'm sure you guys are tired of hearing me talk. Um, Big things, right? Safety. Safety is key, right? Like the whole thing is the patient can explain depression and what the medications are. And the big thing is safety, right? Orthostatic hypotension, the sedation that can come with it, not using it with alcohol, things like, being adherent to the medication regimen so they can actually get better, going to therapy, things like that, right? And then implementation, look at that compliance. You're going to see that a lot. Compliance, 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 because if a patient isn't compliant, they're not going to get better. Finally, we're at the near rear end tail of this big giant chapter that is chapter 16, right? ADHD, symptoms of ADHD, getting distracted easy, failure to receive and follow instructions, right? Because you can't focus on one task at a time, right? Difficulty remembering, that kind of goes hand in hand with the whole frequent loss or misplacement of personal items. So these are kind of paired together. A lot of memory issue, right? Like cognition, stuff like that. Excessive talking, kind of like what I'm doing, right? Interrupting, sometimes I do that too. That's sorry about that. Inability to sit still, that's just, impulsiveness, sleep disturbance. Like not it doesn't really take a crazy amount to really identify these with hyperactivity, right? For ADHD. So CNS stimulants, right? And I did add this little box. I added it, and it has all the other CNS stimulants, and I'm noticing a naming pattern, thank goodness, right? And I added the brand names as well. But the generics usually either end with amphetamine or methylphenidate or some kind of, they end with phenidate or methylphenidate or amphetamine. So thank goodness the naming structure is, it follows through with each other. But our prototype drug will be methylphenidate, right? So Ritalin, right? It heightens awareness, it increases focus because again, the issue with people with ADHD is that they're overly stimulated and they can't focus on one task. But CNS stimulants, more often than not, help produce more focus, more attention, more. Your body is more. It's kind of like a sympathetic nervous system response. Your body is more attentive to your environment. You're kind of more in tune. So, kind of interesting how people who are overly stimulated, like in ADHD, happen to benefit off of the use of a stimulant. So it's kind of cool. It's like fighting fire with fire in a way. Primary use is obviously ADHD and big adverse effects, right? Insomnia, because it's a stimulant. You're doing fight or flight. Do you sleep in fight or flight? No, you don't. Nervousness, right? Anxiety, because you're stimulated. You're having, again, your body is in a fight or flight symptom. Anorexia and weight loss. So the big one there, especially with like kids and stuff, think about it. This drug is basically meth. I mean, in fact, look at that. Look at this up here in the top right corner. Methamphetamine. This is just straight up meth. So, not to be crass, but more often than not, when do you see a person who is really keen of methamphetamine that happens to be on the heavier side? Not really. In fact, it's more they're like on the skinny side, right? Because they don't eat. They're too up. They're too active because they're overly stimulated. It's a stimulant. So I was trying to say it in a nice way so it doesn't sound too like mean, but I mean it's kind of true in a sense, right? It's just pattern recognition, right? But okay, so big thing, right? What does it do? It activates the RAS, reticular activating system, not to be mistaken with the other RAS that we have in our body. But We went over this in a couple weeks ago. All it does is this activating system, all it does is just, hey, are we going to go to sleep? Should we have attention? That's all it's doing. And in this case, have more attention, more alertness, right? And it's achieved by the release of neurotransmitters such as norepinephrine and dopamine. So more attention, right? Impulsiveness, it treats impulsiveness, hyperactivity, disruptive behavior, and it's reduced in a couple weeks. Look at that. Takes time like we've seen before. These changes promote improved psychosocial interactions and academic performance. They're abused a lot in colleges, surprisingly enough, because they maximize your focus, they maximize your attention, and your ability to sit and study for like almost 20 hours or whatever. So I don't know, kind of interesting. Um, Sustained release tablets. We've already seen these